Hi, everyone. I'd like to welcome you to today's AHRQ web conference on the use of health IT to improve healthcare delivery for children. Although a few people are still logging in, we are going to go ahead and get started on time. My name is Ed Lomaton, and I will be moderating today's webinar. I currently serve as a medical officer and chief of clinical informatics in the Center for Evidence and Practice Improvement in the Division of Health IT at AHRQ. Before we get started, I'll just need to repeat a couple of the housekeeping items, and then we'll get right into the presentation. Here is the agenda for today's webinar. We will be recording this webinar, and the recording will be available via the AHRQ Health IT YouTube channel in about 2 weeks. Copies of the PowerPoint slides were emailed to each of you earlier this morning, and were also available for download as you logged in today. We will also be sending them to participants via email following the webinar. We are pleased to have with us today two esteemed presenters. They include Dr. Jonathan Wald, the Director of Patient-Centered Technologies with RTI International, who will lead the first presentation today. And we also have Dr. Elizabeth Alpern, a Professor of Pediatrics and Emergency Medicine at Northwestern University, who will present on her research second. This webinar event is accredited by Professional Education Services Group. And for those of you who are interested in receiving continuing education credit for participating in this activity, information about how to claim your credit will be presented at the end of the presentations. It will also be emailed to you after this webinar. For the purposes of accreditation, let me note that neither AHRQ, AFYA, RTI, PESG, Dr. Wald, Dr. Alpern, nor myself have any financial interests to disclose. Additionally, no commercial support was received for the development of this learning activity. Just a brief note about questions. We have reserved time at the end of the presentations to address participant questions. However, during the presentations, feel free to submit questions that you have for the presenters using the Q&A panel located on the right of the PowerPoint slides. As a reminder, participants are in a listen-only mode, so to ask questions, you will need to use the Q&A panel. This slide shows the learning objectives for today's webinar. By the end of the presentation, you should be able to, 1, describe recommendations for electronic health record functionalities expected to improve the safety and quality of care provided to children, and 2, discuss the development and potential impacts of multi-site performance measure reporting using an EHR data-driven pediatric registry. And now it is my pleasure to introduce our first presenter, Dr. Jonathan Wald. Dr. Wald leads the Digital Health and Clinical Informatics program at RTI with over 20 years of experience in medical informatics and consumer-facing technologies. His work in academic, corporate, and research settings focuses on technology used by patients and providers to improve communication, safety, clinical decision support, clinical outcomes, and the patient care experience. He received his MD from Brown University, psychiatry training at Dartmouth Hitchcock Medical Center, informatics fellowship at Boston's Beth Israel Hospital, and an MPH from the Harvard School for Public Health. And now it's my pleasure to turn the control over to Dr. Wald.
Great. Thank you very much, Ed. And hello, everybody. Let me just make sure that my slides are working. Great. Okay. Well, what I'd like to do today is to talk about the Children's Electronic Health Record format, and specifically a project that was started last year, actually started in 2014 and finished in 2015, to develop something called the 2015 Priority List. And on the next slide, I have some acknowledgments. There were a number of folks on the RTI team, and as well as it was a really collaborative effort. So Ed Lomaton, our moderator, was the project officer for AHRQ. We had Barbara Daly from CMS, also in a sponsorship role. And then some key folks from Vanderbilt University Medical Center, Kevin Johnson, Chris Lehman, and Mark Fritz, as well as Vanessa Short from the American Academy of Pediatrics, and Vicki and Sarah from C3 Consulting. So it was a great team, and it was a really interesting project. The background to the work really begins with kind of a long-standing challenge in using electronic health records very effectively in the care of children. And folks who look at this area, people who practice, taking care of kids and using EHRs can very easily talk about the kind of limitations or challenges or sometimes frustrations that they occur. And some of these are very general because, EHRs are not always the easiest tools to use, and they're also in a state of change and evolution and growth. There are specific problems, though, related to the care of children, and so under the HITECH Act, which called for improvements in health IT, there was a project that was launched by AHRQ with CMS funding to develop something called the Children's EHR Format. And that project began in 2010 and lasted for several years. And the idea was to develop and then publicly release a set of requirements, functional requirements that would be relevant to EHR designers and implementers and users. And so that group of functional requirements, which is known as the Children's EHR Format, and I'll just be calling it the format in this presentation, that was released in early 2013, and then in December it was released interactively over the web at a website called ushic.arc.gov. USHIC is the U.S. Health Information Knowledge Base, and it's a great resource for a number of things. You can visit it, and you'll see on the right side of it, you'll see a tab for the Children's EHR Format. The next piece of background I wanted to mention that's really important is that at the same time that this format, this set of requirements was being developed, there were two states that began to evaluate the work that was being done on that project. And North Carolina and Pennsylvania basically had CHIPRA-funded state grants, and they began working with these functional requirements to try to figure out how they could use them to improve the way they used EHRs and improve the way that they took care of children. And so on the heels of that came the project that we're talking about today, the Format Enhancement Project, and I'll talk a little bit more about the motivation specifically for that and what we did. But the work product from this work is the development of the 2015 priority list, as well as the development of a set or a list of recommended uses for the Children's EHR Format. So this is just a quick recap again that the format work that was done earlier developed a pretty large list, 547 functional requirements, each one of which was a statement about something that an electronic health record system should functionally be able to do. It covered a broad number of topics, 26 topic areas. That work is published on the USHIC website, so that's been live on USHIC for several years now. And the work that they did was based on environmental scan and a gap analysis, work with standards organizations, and engaging a diverse set of stakeholders. So you can go and find out more about that work. But it was really a substantial effort and really a good work and contribution from just a number of key folks from the industry. This slide just gives you examples of what's really contained in the format. So these are just the topic headings. So it's everything from well child and preventive care, which had 131 functional requirements associated with it, to security and confidentiality related requirements, medication management, and as you go down, growth data, newborn screening, immunizations, pretty broad. On the right-hand side, you can see specialized scales and scoring that relate to children, adolescent and adolescent obstetrics, community health. So there's just, when you add all these up, you actually get more than 547 because one requirement can be associated with more than one topic, and often is. So the next couple of slides, I want to talk about the state grantee experiences in North Carolina and Pennsylvania, because in our project, we spent several months developing essentially a case study where we went and we met with these grantees. So these were practicing pediatricians, their EHR vendors, and basically they were asked as part of the CHIPRA-funded work to review each of the format items one by one and assess how well their EHR matched the capability and figure out if they could implement the capability if they hadn't already been using it. And so what the RTI team did is they reviewed artifacts from that work. We went on site visits. We interviewed a total of 44 individuals that were across the two states to find out what their experience was like. And we wrote up a report, and that report is an appendix in the final report that's available on USHIC. And so I want to summarize what we found. The first thing, and probably one of the most important things, was that the grantees felt that this was a positive thing, that having this list of requirements provided a helpful framework for them both to think about their EHRs and to have conversations about how to make their use of electronic health records better. Sometimes those conversations were within a practice. Sometimes they were with an IT organization that they were working with, either in-house or out-of-house. Sometimes they were with a vendor. But the idea that this created a way for them to communicate was just one of the most important findings. Whenever you spend time delving into these kind of things, you usually come out with a little bit of a better understanding of what electronic health record capabilities are and what they can and can't do and so on. And so that was another finding that was a positive that was reported by the grantees. When we asked them what were the high priority areas as they looked at these functional requirements, they identified a number of them, and not everybody agreed on the priorities. They differed from group to group. But on this slide, at least, I just wanted to list a few of them. So the first one relates to being able to automatically calculate percentiles for essentially not only growth charts, but things like blood pressure. The second one mentioned specialized calculations because for conditions like Down syndrome, for example, the growth charts are not the same and they need to be tailored. The third one was around integrating existing screening tools and educational resources into decision support and into their workflows. There was frequent mention of the need and the importance of exchanging information in various ways. Integrated reporting and decision support, not only for the individual patient, but for a panel of patients. And then the last one listed here is family linkage to siblings. So, a productivity tool, and also it helps with accuracy to be able to have updates that affect multiple members of a family able to be carried through. We also asked about challenges. And on this slide 13, we're listing the main or the most mentioned challenges from talking with grantees. So they mentioned that the requirements, the 547 functional requirements in the list, were not always easy to interpret. The language used in those requirements was sometimes technical in nature. Sometimes it was vague, or it was often the case that if you sat two members down in a practice and they were reading the same list of requirements, that they would have kind of discussions and almost friendly debates about what these words actually meant, different interpretations. They also mentioned that it would be very helpful to have some clarifying material, like examples, that might make some of these ambiguous things really clear, but those were not generally included. They also mentioned that setting priorities about what to tackle was really challenging, and not only challenging, say, within a group of users like pediatricians and their staff, but it was also challenging for EHR vendors, and it was similarly challenging for implementers because with limited time and energy and resource, there was always the question of, well, what do we need to focus on? We can't really do 547 things right now. The next thing that they reported was that although they, in many cases, even found that their EHRs had functional capabilities that matched items in the format, that they weren't always able to implement them. It could be that the specific way they were implemented in the electronic health record was, didn't suit them, or it could be that their workflow wasn't adaptable. So they just found that adapting EHRs wasn't that easy, and not a surprising finding, but it was one that was really mentioned, prominently in our work. And then the last one here is that no matter who you spoke with, it was fairly easy for them to come up with missing requirements, which is really interesting because 547 functional requirements is huge. And on the one hand, they're saying we need to prioritize, but on the other hand, there's also a feeling that there's a lot to cover here, and when will we be done with this? Maybe we'll never be done with this. So there was a lot to learn from talking with the state grantees. The next focus of our work was to convene a multi-stakeholder work group, and this work group met for 6 months in early 2015, a very distinguished group. And I wanted to just pause for a minute to point out that when you look at the folks on this list, you see policy experts, software vendors, academicians, informatics experts, medication-focused experts. There's Electronic Health Record Association, so practicing nurse practitioners and physicians. So it was 19 folks. They worked very hard, and it was led very ably by Kevin Johnson and Chris Lehman from Vanderbilt. And this group was charged with making sense out of and figuring out how to enhance this large list. We also convened a federal work group who are listed here that represented a number of key agencies that are interested in the health of children and the delivery of care to children, as well as, in some cases, informatics. So between these two groups, we then followed a process that we made transparent as we worked through it, where we took the original format, which not only was 547 functional items, but even more than that because of some additional items that were added to help organize. And the project team developed internally a straw man list of 166 items, which when we really looked at them could be deduplicated down to about 99 items. That list was presented, was shared with the multi-stakeholder work group, and they developed with the team a process for deciding which items should be in, that is, should be on a priority list, which should be off a priority list, and which ones we weren't sure about and should be discussed. And then through an iterative cycle of discussions in small groups and then making some changes and then reconsidering, in the end, the group developed a list of 47 items, and those 47 items are what you will find if you look at the 2015 priority list. There were inclusion requirements and there were exclusion requirements. And some of the exclusion requirements point out that if an item was a very important priority but it applied to everybody, not just kids, it was excluded because this project was intended to focus on the care of children. So that's kind of the first hint that something could be really important and still not make the list, not because it wasn't important, but only because we had to develop ways to constrain and to focus the work in this project. So if you look at this next slide, you'll see the same 26 topics that I showed you earlier. And you can see that a number of those topics are addressed in the 2015 priority list, but some of the topics aren't. So on the right-hand bottom where you see zeros, in the most right-hand side of the slide. The group did not choose items to be on the priority list that happened to fall in those particular places. And you can see how many items in each of the areas made the priority list. And again, nobody had a goal in mind for how many should be in a particular area, but this is just a presentation of how it looks now that the work is done. The next couple of slides are examples. So if you were to look at the priority list, the first item, which has an ID number of 2001, says as a functional requirement, EHR should link maternal and birth data to the children's health record. And then there's a description. Now, if you really want the details and you go look at the full document, you'll see something called implementation notes, which have many, many fields that are specified because the work group really looked in detail at many of these things and wanted to provide supporting materials. So you'll find that as an example in ID 2001. 2005, medication management. This one said that when using an EHR and selecting the dose of a drug, the system should provide the closest available and standardized dose. In other words, it shouldn't allow doses that are very hard or maybe just very difficult for a pharmacist to actually formulate. And on the next slide, I think we have a few more examples. Growth data, a really important area, talks about recording vital signs and growth parameters precisely, which actually varies with age. You record it differently from newborns to children who are under 2 years old, and then on from there. So again, in the implementation notes, there's a lot more detail about what this means and how one might implement it. The next item is just a kind of a straightforward one, and maybe needs to be iterated on even further. But it says it's not okay just to allow gender of male or female. There need to be other choices. And so the next slide and the next two slides now shift from the priority list, which is 47 functional requirements, to talking about how the priority list might be used. And as I mentioned, when we did this work, we put our heads together to include in the report some early thinking about who actually should be looking at this priority list and how might those individuals or those groups use them. And I also want to mention that the priority list of 47 items doesn't really replace or take away from the functional requirements, the big list that were developed originally in the children's EHR format. They're different, and so we'll probably come back to that. Actually, I'm guessing in the discussion. So in terms of direct uses, the thought was that providers and their staff who use and who choose EHRs can use this priority list to basically inform their RFP development or their request for information to make sure that the EHR that they are potentially going to procure has functionality that's really important and that meets the requirements on this list. I mentioned earlier that we anticipate this list will support more productive discussions between providers and vendors and any stakeholders who need to kind of sweat out the details of how these systems work and support the care of children. There are always ongoing improvements in the way that EHRs can be used, and some of those improvements are based on local changes, like changes to workflow or changes to configuration or changes that happen after a new release of an EHR is made available. And also for software developers, the next section, we anticipate that this list will be directly useful to them because they're actually working on functional requirements and may be able to adopt what's on the priority list, at least as a starting point. Now, anyone who's been involved in software development knows that the way you translate functional requirements into software specifications, involves a bit of work, and also a lot of times refinement and decisions, and there's more to it than just taking the functional requirement statement and poof, it's ready for the designers and the developers. But at least this would provide a starting point. That's the idea. Not only in terms of the design and the product roadmap for an EHR, but for interoperability, because the thought is that if a small set of functional requirements is implemented across the board, then that will really raise the likelihood that some of those requirements that deal with interoperability will be widely available. The next list, which is longer, is a list of indirect uses of the 2015 priority list. And so just looking at the stakeholders on the left side, the thought is that user advocacy groups and folks who evaluate electronic health records and users, they might use this list to try to surface opportunities to improve workflow and essentially to do quality improvement cycles of various kinds. That school districts might have use for the priority list. In other words, if they're more aware that EHRs can send certain kinds of immunization data, and the way that works is specified, then maybe the school districts can make sure that their systems can receive that information or can send information back. Government agencies like CMS and state Medicaid agencies, as well as others, could understand from this list where some of the priorities are right now in terms of closing gaps around electronic health records used for children. And if there are relevant policy issues, then those could be addressed. Standard development organizations is listed, and as you go down the list, there's just no shortage of stakeholders who might find that it's useful to know about this or perhaps to use it in some way. The last item is important for safety reasons, the idea that pharmacists and pharmacy staff and others who deal with pharmacy management systems could use the priority list, use the children's EHR format to improve the way that medications are used safely. This slide is just really a screenshot of the USHIC website because we felt that in terms of communicating and disseminating this information, this is really important. And when we finished the project in early December last year, we were very hopeful that the USHIC website would be able to, make changes to accommodate this new work. They moved very, very quickly. So the system went live at the end of April, and so it was sort of great to be able to report that you can go there now and you can access a lot of detail about this. And here I'm just showing the tab on the right that's highlighted, the children's EHR format in purple. That's where you click. And then on the right-hand side, you'll see downloads of both PDF and Word documents that that include the full report. I'll just mention as a detail that some of the requirements from the original format work, as well as our work with the 47 in the priority list, trace their roots back to HL7 work. And HL7, a standards organization, makes that stuff freely available to use, but they do also require that you sort of check a box and agree to some licensing terms. So when you go to this website, if you're prompted to go to the HL7 website to agree to some licensing terms and so on, you should probably just go ahead and do that because then it gives you the full unabridged report. But even if you don't choose to do that, you'll get what's called an abridged report, which is it sort of hides some of the HL7 licensed material. There's no cost. It's a couple of simple steps, and so it should be easy for anybody who's interested. So on the next slide, is really a summary and recommendation slide just to recap that this priority list is these 47 high-priority functional requirements. It covers 19 topic areas. There are these implementation notes for each one that provide some additional guidance. And it's really not meant to be comprehensive. It can't be. It's too short. But it's a starting point for a number of important activities. It's available on the website. And the recommendations, the high-level or top-level recommendations coming out of this are really that the group felt that the 2015 priority list was an opportunity for industry stakeholders, all of whom have a stake in getting children better care through better EHRs, to work together. They also felt that this work isn't finished and that there ought to be more work and more collaboration to continue to improve the format. Some of the things we learned along the way were that this sometimes gets complicated and in the weeds, and it takes a substantial amount of focus to identify what improvements to make and how to word things. We also understood that the priorities that led to the 47 items, they could shift, and not everybody on the group was unanimous in which items should make the list or should not make the list. So stakeholder coordination is really critical for improving the list over time and also for making this work have impact. I'm just going to mention one or two more things quickly before I'm done with the presentation part, and then I guess we'll take questions and answers at the end. We did a crosswalk to see how the items on the priority list compared to some other guidelines or regulations that were out or in progress. So we compared them to something called the HL7 Child Health Functional Profile, Stage 2 certification criteria, and Stage 3 proposed criteria based on the timing of when we did our work. And in the top row, you can see there was a lot of overlap, like 45% of the items, of the 47 items, were found with a close match somewhere in the HL7 Child Health Functional Profile. No big surprise because the original format had used that functional profile as one of its kind of core starting points. And so many of those items made it into the priority list. It's also not surprising that there was very little overlap between items on the priority list and things that were identified in either Stage 2 or proposed Stage 3 certification criteria, because the focus of the certification criteria was really quite different than focusing on pediatric-only areas, and we excluded things that we thought were covered elsewhere, and so we tended to exclude focusing on things that we thought would be included in the certification criteria under meaningful use. So that like low 4% probably means we did a good job of not overlapping with other regulations. Some limitations that we wanted to recognize. First of all, these are definitely subject to change because as users' needs differ, as products mature, maybe products mature to the point where they've covered most of these and this priority list is kind of outmoded. It needs to be redone. They do reflect a specific context, not only based on the membership of the work group, but the time available to do the work, our kind of in and out criteria that I mentioned. We got some feedback along the way that was helpful, but also probably influenced, the ultimate decisions. And as I mentioned already, everybody should recognize that they're not kind of shovel-ready necessarily for an EHR developer, but they really should provide a very strong basis for design teams and implementers to go forward. So with that, I'll just mention some areas that were not really addressed during the project, but were very specifically identified as being important for future work. And one was immunization forecasting, which is complicated, and that was the main reason we didn't kind of finish addressing it during this project. The fact is that specific populations oftentimes get short shrift, but are in need of functionalities in EHRs quite a bit. Quality measurement. This is such an important area, but it was just not the focus of this group. The group focused more on what clinicians and direct users would find useful in the direct care of the individual, and they kind of made a choice early on that even though QI was critical, it was just not as high a priority for this conversation and this work. And then, of course, future work needs to continue around health IT standards, data harmonization, and data exchange. And with that, I'm going to skip over the recommendation detail. You have the slides. You can take a look at it, and just conclude with that. And thanks, everybody, for your attention.
Thank you very much, John. As a reminder, we'll be taking questions after both presentations, so please submit your questions for Dr. Wald to the Q&A panel to your right. Let's move on to our second presentation of the webinar, which is being led by Dr. Alpern. Dr. Alpern is a professor of pediatrics at Northwestern University School of Medicine, the associate division chief and attending physician in the Division of Emergency Medicine at Lurie Children's Hospital. Dr. Alpern is also an epidemiologist with longstanding interest in improving the quality of emergent care delivered to children. Dr. Alpern has been a member of the Pediatric Emergency Care Applied Research Network, or PECARN, from the network's inception in 2001. She is the principal investigator for an ARC-funded project to develop the PECARN Emergency Care Registry. Now I'd like to turn the control over to Dr. Alpern. Welcome.
Thank you very much. I'd like to very much thank you for asking me to speak today. I did want to acknowledge our supporters of this work. Obviously, we are grant supported through ARC and very grateful for that, as well as the PECARN infrastructure support through the Health Resources and Services Administration, HRSA, and Maternal Child Health Bureau through cooperative agreements with emergency medical services for children. First of all, I'd like to take a moment to point out the rationale and impetus behind our project. As noted in the IOM report, Emergency Care for Children, Growing Pains, the emergency care provided to our children in this country is highly variable. At times, it's really outstanding, and at other times, it may be significantly lacking. This variability presents an opportunity for improvement. In attempting to enact this improvement, it became evident to us that basic administrative data was severely limited in providing adequate reporting of the variables needed for performance measure derivation to assess and report the quality of care provided to children. We then identified possibilities introduced by ongoing advances, particularly in the wealth of patient-centered data available in electronic health records that are used every day within the emergency care setting, as well as technical advances such as natural language processing that may help us explore that wealth of data. And we believe that this combination provides an opportunity to harness the strengths of the EHR data to measure quality of care and thus impact or improve the care provided to our children. So the overall aims of our current project is first to develop an emergency care visit registry of pediatric patients. The registry is derived electronically from EHR data from different hospital emergency departments with differing electronic health record data sources, and I'll go into that specifically in a few minutes. This registry serves as the foundation for the current study I'm going to describe, and we sincerely hope for future studies as well, obviating the need for resource-intensive chart review. This second aim of our project is to use this registry to collect stakeholder-prioritized emergency care performance measures for important pediatric medical and trauma conditions at the level of both the emergency department site as well as individual clinicians within each site. Using this performance measure data, we will develop achievable benchmarks of care to promote performance improvement. Our third aim is to use the registry to report performance to individual ED clinicians and sites. We are testing the hypothesis that providing regular performance measure feedback will improve their performance and decrease variation among ED clinicians and sites. Our work is undertaken within and with the support of the Pediatric Emergency Care Applied Research Network, or PECARN. As Ed mentioned, PECARN is funded in 2001 by HRSA and EMSC and is made up of 18 member hospitals and a data coordinating center at the University of Utah. PECARN's overall mission is broad to conduct research and answer questions related to pediatric emergency care along the spectrum. Due to time, I'm not going to go in depth about PECARN, but I will refer you to the website as listed here, and much information and contact personnel are within this website. One of the early studies undertaken by PECARN and influenced the derivation and development of our study was led by Evie Alessandrini at the University of Cincinnati, and was to derive a parsimoniously grouped group of clinically relevant, stakeholder prioritized, and endorsed pediatric emergency medicine quality performance measures. We came up with 60 such measures, all of which are available online through the PECARN website or the EMSC National Resource Center, as noted here. This work allowed us to choose, endorse, and rigorously selected performance measures to implement within the PECARN registry project. I have these measures that we selected for our current PECARN registry project here on this slide and the next. Our first group was a cross-cutting group of measures with the initial care of every ED in the patient, such as measuring weight in kilograms or measuring vital signs for all ED patients. We then looked at emergency department flow measures, such as the ED door-to-provider time or the total length of stay. And then we looked at an overall quality and safety care relevant to every emergency department patient by looking at ED return visits within 48 hours and return visits that resulted within admission to the hospital within 48 hours. We also then chose some clinically distinct performance measures listed here. The first related to childhood infections, hoping to reduce antibiotic use in children diagnosed with viral illness, to improve our pain and sedation of those patients with long bone fractures, and to impact respiratory diseases, particularly in this case asthma, by improving our use of systemic corticosteroids in an acute asthma exacerbation, and looking at the timeliness of inhaled beta agonists in treatment of asthma, and also our improvement scores and documentation of asthma scores in these patients. So the basic premise of the registry overall is, so to say, one-stop shopping. We wanted to use an electronic health record to derive measures, to report them, and then to assess improvement on the quality of care provided to our children in the emergency department. As you can see in this schema, if you start on the top left section, there's the patient electronic health record for all ED visits from 7 sites. And we'll have monthly data transmission from each of these sites temporarily related to the end of the month. So I'll go over that in a moment. In a joint venture between the sites and the data coordinating center, there is both validation and de-identification that occurs as that data is transmitted to the data coordinating center. The data coordinating center then forms what we call the PECARN registry. And that is a repository of this entire electronic health record data of all ED visits from the 7 sites. We then use the data within the PECARN registry, both distinct variables that go directly into the performance measures, or we undergo natural language processing with free text narratives to help us populate our performance measures. We then take these performance measures and set benchmarks of care from the actual data within the registry and can derive both site-specific and provider-specific measures. We do this in a timely fashion and then provide report cards back to both the sites and the providers. And of course, our overall goal is to improve patient care. These are the sites and the EHR vendors that are included in the project. All of the sites listed here, except the Children's Hospital of Philadelphia, gives data on 2 EDs that are associated with them, both a main emergency department and a satellite emergency department. So in essence, we have 4 health systems, but 7 distinct emergency departments involved in the project. I also wanted to give you an idea of the scope of the registry and the data variables we collect. In essence, we wanted to capture the full care provided in the emergency department. We cover soup to nuts of everything that happens in the ED. And as timeliness of care is so central to everything we do in the emergency department, almost every variable has a date and time stamp associated with it. As you can see, we collect information on both the site and patient identifiers. This is a unique patient identifier that allows us to follow patients longitudinally throughout the study. We have patient demographics, and then visit information that starts at triage with both a triage category, chief complaint, and arrival mode, and then has date and time stamps for notification or pre-notification of emergency department arrival, the emergency department door time, sort and triage time and date, and then disposition from the emergency department time and date. We get information on every provider that touches the care of that patient, and then we have repetitive documentation of any vital signs that are assessed during the emergency department visit. And we have information on both current medications that the family or patient tell us that they are taking as they arrive to the emergency department, any medications ordered and given within the emergency department, and then medication prescriptions that are provided upon discharge from the emergency department. We also have clinical assessments such as the asthma score, pain scores, and Glasgow Coma scores as they are recorded, both date and timed, throughout the ED care. We collect the narratives with a date and time associated with it, the author type, and then the free text of the narrative. We have radiology orders, date and time, start of the process date and time, available of the radiographic information to be viewed by the ED providers, and then the report as it is available, its date and time, and the actual radiology report. We have labs both ordered and results of those laboratories as they were done in the emergency department. We collect information on procedures and diagnoses, as you can see there, and then we have disposition from the emergency department. We only have two variables that occur in care outside the emergency department, and that is for patients that were admitted to the hospital, we have their ultimate hospital discharge date and time, so we can derive the length of stay of hospitalization and the vital status of the patient upon discharge from the hospital. Currently, we have data from 7 sites starting in 2012, and as I described, we have monthly transmission of data approximately 30 days after the completion of the calendar month. So I wanted to give you the scope of the registry from 2012 to 15, but realize we've had data transmission of May 2016 actually yesterday. So these numbers are increasing monthly as we move forward. As you can see, we had over 1.7 million encounters over those 3 years in the PCARN registry with over 760,000 unique patients. We have over 10 million laboratory results, 2.3 million medication orders, and uniquely for our registry, I believe, 11 million narrative notes from the emergency department care. So to review, the process of the registry is that we have a year of data within the registry built directly from the EHR data, and from that we derived performance measures from the EHR data. We determined benchmarks of each of the performance measures over that year, including summary statistics and achievable benchmarks of care, which is basically the median performance of top providers, and I'll give some examples of this in a moment. We then have a temporally related transmission of recent months data, and we then derive the quality of care performance measures from the last month's data at both a site and provider level. We put these performance measures into a report card and distribute them to the providers and leaders of the site to effect change. We then assess the impact of the report cards by measuring change in the performance measures over time directly from the data within the registry. So for example, June 2016 is ending today. We'll allow some time for this to pass for the data to mature, i.e. for lab results to be recorded, diagnosis codes to be determined, narrative notes to be finished, etc. And then approximately 30 days after the completion of the month, so for this example, on July 29th, the electronic health record data will be submitted to the Data Coordinating Center. We will do quality assessment on the data and lock it within 1 week. We then take about a week to populate the performance measures with the new data and produce the report cards. The report cards are then emailed out approximately 6 weeks from the completion of the month. And on average, we email 450 report cards out monthly. The report cards, some information about the report cards are that the visits at the provider report cards are attributable only to that provider. So it's human nature for somebody to say, well, the performance measure for my site is not related to me, but to others if it's not encouraging. But we give the providers information directly on the report, on the visits that they provided care to the patient. Because this is a research study that is blinded to anybody but the provider, so it is not known to the director of the emergency department how each of their providers currently are performing. We have stringent case identification for our cohorts, and I'll go through some examples of that in a moment. And the number of cases involved in the measure is provided usually on a monthly or a rolling quarter count depending on the performance measure. We give graphic representation of the performance, including trends over time, and we also allow for comparisons of performance on a site level, a network level, and then an achievable benchmark of care of the top performers. So the achievable benchmark of care is a mathematically measurable level of excellence that is objective and reproducible. It uses providers with the highest attainable performance to determine the benchmark and uses a correlation factor so that providers with small numbers of visits do not have undue influence. This is an example of the components of a provider-level report card. This one is, the measure is related to systemic corticosteroid use in patients with acute asthma exacerbation. A provider notes their performance. In this case, this provider has an average of 84.4% of his patients with asthma being treated with systemic corticosteroids in the emergency department. And the N of the visits that make up this measure are next to it. It has the site's performance so that the provider can compare themselves to others within their own site, and then the network performance so they can see how others at other peer institutions are doing. Then we provide the achievable benchmark of care, so those top performers, if somebody wants to see how they're doing compared to top performers. We show variability of the providers within the site. As you can see here, the provider that is receiving this report card is that red rectangle, and all of the other providers within that provider's site are represented by individual gray rectangles, either above or below that provider, so that provider can see where they fall within their site. We then have trends over time. We both provide the trend over time for the single provider, as well as trends over time for the network benchmarks and the site benchmarks. This is an example of how a provider report card looks. All of the different measures are given their own due. And this is an example of the site report card and how a site will be able to compare themselves to other sites within the network. So for an example of one of our performance measures, we wanted to review or to see how we are doing for improving pain in patients with long bone fractures. And I'll just walk you through our process of determining the cohort. First, we take all visits in the registry. We then use those that are seen by a licensed independent provider, so we exclude patients that left without being seen. We then determine those patients that had a long bone fracture, and for this performance measure, we use both distinct ICD-9, ICD-10 diagnosis codes, as well as natural language processing of the radiology report. We then determine if a pain score was documented for a visit, and if one or more of the pain scores were indicating moderate or severe pain, the patient is included in this measure. We then see, was a pain score reassessment done? And then we want to know the timeliness of this pain score reassessment. So was it done within 90 minutes of the arrival of the patient to the emergency department and before 30 minutes of the emergency department departure? Because if a pain score is documented as the patient is leaving the emergency department, we may not have time to act upon it. And then we want to determine, did we have an improvement in the pain score? And we look both at a 1-point or a 2-point improvement in clinical pain scores as documented. So for example, in documenting pain scores, the overall performance of our network was around 92.9%. The site ranges, though, were 80 to 100%. And the achievable benchmark of care, so those patients cared for by the top providers, we had on average 99.9% of the time documentation of the pain score. It did range at different sites, so the achievable benchmark of care of the lowest site was 91.2%, and the highest site was 100%. In reducing pain for children with acute fractures, so not only did we document it, the children had moderate or severe pain, we had a reassessment, and on that reassessment there was reduction of pain due to some treatment in the emergency department. We see that the overall performance is not as good. We have room for improvement with only a little over a majority of patients having reduction of their pain in the emergency department. The site ranges were very wide, with one site at 35.4% and one site at 72.7%, but the achievable benchmarks of care seem to bring those up. And what we take from this is that the documentation of the pain is mostly at a site impact, where we want to impact improving this is really on a site. If the system of the site has documentation of pain, then it almost always occurs. There's not as much variation between the sites, though there is some, and the achievable benchmarks of those top performers only bring up that performance in a minimal way. Whereas when we look at reducing pain in children with acute fractures, we see the impact of the best practice provider in that even though we're not exactly where we'd like to be, those best practice providers, even within the sites that are at around 35% of the time, can really bring up the performance in this performance measure and have a distinct impact in that. So another one of the measures that we used was antibiotic use in viral illness. We know that there are racial differences in the care provided to children in the emergency department from previously reported studies, especially with respect to use of head CT use, hospital admission rates, and pain management. So we became interested in noting if there were racial differences in antibiotic prescribing, especially because it has been reported that in primary care there are known racial differences in antibiotic prescribing for children with acute respiratory tract infections. To our knowledge, this has not been previously studied in the emergency department setting. So we looked at our performance measure of antibiotic use in viral illness. And again, I'll walk you down the path of how we determined these patients. First, we included all children under 18 years of age who were seen by a provider and discharged from the emergency department. Patients were excluded if they had any complex chronic condition or a bacterial infection as determined by ICD-9 or ICD-10 code. If there was a diagnosis code of pharyngitis, an ICD-9 diagnosis code of pharyngitis, we then actually looked in the laboratory information to determine if a rapid strep test was performed. And if it was positive on the results, the patients were then excluded as they had a bacterial infection. However, if it was negative or not performed, the patients were included and assumed to have a viral infection. We then included all patients who had a diagnosis of an acute viral respiratory tract infection. Our main outcome measure was antibiotic administration in the emergency department and upon discharge. We specifically looked for oral, intravenous, or intramuscular antibiotics and did not include topical antibiotics in our analysis. Our exposure variable was the patient's race and ethnicity, which was categorized as white, non-Hispanic, black, non-Hispanic, Hispanic, or other. With respect to patient characteristics, we adjusted for age, gender, insurance status, and triage acuity level. With respect to visit characteristics, we adjusted for the ED site, the type of emergency department, meaning main emergency department or satellite emergency department. Of the over 38,000 visits that met our inclusion criteria, you can see here there is site-based racial and ethnic variability. Overall, 2.6 of our patients were diagnosed with an acute respiratory tract infection, received an antibiotic in the emergency department. When we examined antibiotic provision by race and ethnicity, we found that 4.3% of all non-Hispanic white children diagnosed with a viral respiratory tract infection received antibiotics. This is in comparison to 1.9% of non-Hispanic black children and 2.6% of Hispanic children and 2.9% of children of all other racial groups. These differences were all statistically significant. In our multivariable analysis, we used non-Hispanic whites as our referent group, as you can see that red line there. And compared to whites, non-Hispanic blacks had the lowest odds of receiving antibiotics for viral acute respiratory tract infection. Hispanics and those of other racial groups were also significantly less likely to receive antibiotics for viral acute respiratory tract infection after adjusting for gender, age, insurance status, acuity level, ED site, and ED type. In comparison to other non-ED studies, we found that the overall rates of antibiotic provision for viral acute respiratory tract infections was actually very low. However, we found differences in antibiotic provision by patient race and ethnicity. And these differences persisted after adjustment for confounding. The next steps of our project are to continue over our benchmarking and disparity assessments, and then to assess the impact of the report cards. As I've said, we're using the data within the registry to measure change, and we are currently just beginning to see both how our performance measures are before handing out our report cards and what the impact of the report card distribution is on the performance measures after that. For the future directives of our project and registry, we hope to expand to all components of care, including pre-hospital, emergency department, inpatient, and potentially primary care in the future. And we hope to use this rich clinical data derived from the electronic health record to fully evaluate the effect of diagnosis and treatment on important validated outcomes. Of course, research is certainly a team sport, and I really just want to put out here the many people within the sites and the Data Coordinating Center, as well as EMSC and the PCARN Steering Committee that made this work possible. Thank you very much.
Thank you, Dr. Alpern, and thanks again to both you and John for your very informative presentations. As a reminder for everyone listening, if you have a question, please submit those to Dr. Alpern or Dr. Wall using the Q&A panel to your right. A quick few more items about that. So we're done with the content portion of the webinar, and we do have a good amount of time for questions. Please do type them into the Q&A section on the WebEx portal. And we may not be able to get to all of them, but we will answer them all in writing and send the answers out to all attendees. A few questions did come in during their presentations to both of our presenters, and I want to start with one for Dr. Wald. So, John, this question is about the children's EHR format and specifically about the school-based linkage component. This person who's asking the question says she's working with a large school district in Illinois, and there are concerns with HIPAA from providers sharing EHR information with the schools. She's wondering about your thoughts about that. And I'm going to expand it a little bit to if you could describe if this was a part of the conversation with the multi-stakeholder work group.
Okay, thanks, Ed. Overall, I think that this question about HIPAA-related, policies and practices was out of scope for what the work group really focused on. What the work group was focused on in their conversations and thinking around schools was was more about for areas where there is a clear need and policies that support sharing of information, like, for example, around immunization records. How best can EHRs support that? Are there mature standards for doing that? Can requirements or functional requirements be specified in a consistent and a reliable way that it would help designers and developers of systems implement them? And so I think the question kind of brings up a couple of things that are maybe kind of just worth sharing about the format work. One is that the group recognized that there were certain areas where functionality requirements were really well understood, and there were other areas where, for various reasons, they weren't, or they were complex, and there was a lot of, a lot of variation, say, across different states or across different kinds of practices. And so, in trying to come up with a focused list, the group naturally worked in areas where the knowns, sort of outnumbered the unknowns. The areas of policy were especially challenging because we were trying to do work that would appeal nationally, and so for federal policies, okay, that's not a big challenge, but for things that vary from state to state, and states do vary in the way that that they treat sharing of information, then the group tended to stay away from that. Ed, you may have more things to add from your perspective to this, which would be great. And I should also mention that I'm not a pediatrician, so there may be some pediatric-specific pieces of this that I may not catch in terms of my response.
John, this is Ed. So I agree. That's a great answer. I would also just, while you were presenting and I saw this question, I did go to the UCHIC website, and there are several requirements in the 2013 version of the format related to school-based linkages. So for this person who asked that question, you might take a look at those. But as John pointed out, I think there's lots of areas which the group just didn't feel that they were able to make necessarily a lot of headway, and so as part of the focusing, this may not be as reflected in the 2015 priority list as much as they would have liked. Certainly an area of tremendous amount of interest on the part of the group in terms of linking data to lots of other places where kids spend their time, schools being one of them. So I'm going to shift gears a little bit and ask some questions that have come through for Dr. Alpern. So Elizabeth, I'm going to turn to you. I'm actually going to combine a couple questions. And so the first part of this is, for your report cards, this person's asking, did you provide the N, so the number of say, sites or networks in addition to the N for individual providers? She's referencing slide 54, so as I'm talking, I'm going to actually go back to slide 54 for you. And then the second part of the question is a little bit longer probably, but can you say a little bit about how the achievable benchmark score was established?
Sure. So the first question as to the N, I'm going to actually maybe, if you could just move forward to slide 56 for me. Thanks. So as you can see here, the N's on a provider report card are related to the number of visits that the provider has related to that performance measure. And then if you go forward to slide 57, the N is related to the number seen at the site. We don't actually have in the provider report cards the N of the number of sites available or the number of providers within that site. That's something very interesting we can talk about. It's much easier to tell here on the site report card that there are 7 sites And all of the personnel who are reading the site report card know this project pretty well and know that there are 7 sites. So you can count up the actual rectangles in the center visual there and know that there's 7. That's a lot harder to do within the provider report card, and that's an interesting suggestion. As for the achievable benchmark of care, basically that is, as I said, a mathematical calculation that tries to take into account the best provider, the median performance of the best providers, without giving undue influence to those providers that are seeing fewer numbers of patients. So I'll give a quick example of this. What we first do is we calculate the performance of a measure, say corticosteroids, for each provider. We calculate that performance. We then come up with something that's called the adjusted performance fraction, which is done by adding 1 to the numerator and 2 to the denominator. And this helps us account for providers with very few visits. So, for example, if a provider saw a patient with asthma and only saw 1 patient visit and gave that steroids, they would have 100% performance. But their adjusted performance fraction is actually 2 over 3. Add 1 to the numerator and 2 to the denominator, or is 67%. Where on the other hand, if a person sees 198 different visits with asthma, and their performance is also 198% of times they give steroids, their initial unadjusted performance is 100%. But if we add 1 to the numerator and 2 to the denominator, it's 199 over 200, and their performance is 99.5%. So see how that difference in small numbers becomes greater there. And so we then rank the providers using the adjusted performance fraction, and we start at the highest ranked provider, and we move down them until we've reached a cutoff that accounts for 10%, or whatever your cutoff you want to be, of the visits in the performance, and we take that as quote-unquote the top providers. And then what we do is, using those 10% of visits, we adjust, we take the unadjusted performance, so their actual performance, and we come up with the achievable benchmark of care. And I know it's sometimes difficult to sort of verbalize mathematical equations like that. The reference for the achievable benchmark of care is actually on the slide that talked about that in the slide deck. And I'm happy to send that out separately as well.
Thanks, Elizabeth. I'm going to stick with you, and another question, relatively specific. I think if I go back to this slide, this is what might help. This person is asking about, so the antibiotic prescription in each demographic for the viral syndrome. And is this assumed that you're looking across all the children's hospitals? Did these hospitals themselves have different patient demographics?
Yeah, so actually, if you could go back to slide 63, all of these are children's hospitals. Some of them, as I said, are main emergency departments, and some are satellites. And as you can see here, there is variability in the race and ethnic population seen at the different sites. And so we actually did a within-site model as well. I didn't have time to present it, but when we looked at just within-site models, we saw that there was persistence of a difference with non-Hispanic Black children getting lower rates of antibiotic provision compared to non-Hispanic white children at every site. So even when we looked at a within-site model, that did persist.
Great, thank you. John, I'm going to go back to you for a moment and ask you a question. This person is asking about, in terms of the format, priorities or requirements related to protecting the confidentiality of information provided through minor consent, such as adolescent sexual health. And this person is asking specifically if you know of any national advocacy or work groups efforts working on those types of EHR functionality goals. And I'm going to expand it a little bit and ask you if you don't mind commenting on how the work group sort of talked about confidentiality and minor consent around things like adolescent sexual health.
Okay. Yeah, thanks, Ed. So the work group did talk about this issue, although it and I believe it made it into at least one of the requirements. And basically, there's fairly good agreement that below age 13, it's sensible and legally there's legal requirements around providing all information to parents. But then during teenage years, that there are all kinds of issues that crop up around information that should be protected from parental visibility, and also about the problem of pressure, that if you gave a teen access to information differently than the way a parent has access, that the parent might put pressure on the teen to, share the information that they knew was there or they knew they didn't have access for, and so on. So the group recognized that this is one of those areas where there is not yet kind of clear consensus and lots of experience about how to do this well. And so overall, I think the group said, this area needs to evolve before specific recommendations around functionality at a detailed level make sense. I personally know of a number of different organizations that are offering access to teens and teens' parents, and they vary in the way that their policies work. So it's probably appropriate at this point not to be broadcasting a single set of requirements to to EHR vendors and other industry stakeholders while it flushes out. But happy to talk more about that if people would like.
Yeah, thanks, John. I think that's
and actually, Ed, I just remembered. So I don't know right now of a specific resource that addresses this, because I think the question was what resources exist, or at least what groups are working on it. So I guess my first stop would be to check, just to check with the usual organizations like the AAP, but I don't have specific knowledge about that.
Thanks, John. Yeah, I likewise am not aware of a specific group working on that specific question. But again, this is one of those things that the work group really talked a lot about, as John alluded to, but just wasn't able to come up with, or felt compelled or able to come up with a sort of a broad statement that would cover all situations. For the person who asked that question, if or anyone else on the audience, if you do know of advocacy or work groups working specifically on this question, feel free to post that in the Q&A box so that we can all learn about it. Elizabeth, I'm going to head back to you, if you don't mind. And this question is about whether there are educational presentations for the departments, for the ED departments, to help them educate on the overall trends. And I guess I'm going to broaden this a little bit also in terms of how are you seeing the ED departments use the information that you're giving them?
Yeah, thank you. So the scope of our project, as written and funded, was to look at really the impact of the report cards and not do any embedded quality improvement within the project related to it. And our reasoning for this was that audit and feedback has been shown to be one of the best components in leading to improvement in care. But we also, I work with some really outstanding quality improvement personnel, Lala Bajaj at Denver Children's, and Eviela Sandrini and Jim Chamberlain. And, we all know that sort of local boots on the ground impact for quality improvement is really necessary, but was not part of our model. However, that being said, we did have, and we still have, sort of recurring education on the report cards, sort of what the data is, the rigorous derivation of the cohorts, how we derive the performance measures, what the information on the report cards mean, and how to interpret it. We encourage feedback from the providers, and almost monthly we'll get some feedback about, why is this done this way? Can you look into this for my performance measure? And we take that very seriously and do a lot of quality checks on our data to make sure that we are providing the performance measures appropriately and accurately. And then as an example, we also speak, we have a weekly meeting with the site principal investigators for each of the sites, and we discuss information and what has been interesting to me. So for one of the sites, they really were not pleased with their performance on documenting pain scores and in their pain improvement in patients with pediatric patients with long bone fractures. And so what they did is actually did a sort of root cause analysis of that problem at their site. And what they came up with is that the documentation of the pain scores, though we were getting the data in the registry, was documented in their EHR in a place that was really difficult for the physicians or APNs who were caring for the patients to identify the pain scores. So the pain scores might be documented, but a physician is not actually seeing that readily, and they felt that the pain was not being acted on because of that being hidden. They subsequently moved their pain scores to be visualized with every time a physician looked at the vital signs, and that has significantly improved their performance on those measures. We share that information as a group, but it is not sort of done in a set fashion. It's much more anecdotal, and that's just part of the scope of our project. Did I forget one part of your question? I'm sorry. I think I got it.
I think you covered it. Yep.
Okay.
A question for John. First, this person begins with a thank you for your efforts to make EHRs better for clinicians caring for children. And this person is asking if there are similar resources for priority lists for pediatric-specific patient portals. So, for example, adolescents and families taking care of children.
I agree. There's a need for resources. The only thing, I don't have a specific resource in mind, but I'll mention at least a couple of thoughts. One is that the California Healthcare Foundation has done some good work in patient portals, and so if you Google CHCF, California Healthcare Foundation, and patient portals and resources, you'll come up with a few things. They commissioned, I believe there's a white paper a few years ago, and they've got some resources on a website. I don't think they're specific for kids or pediatrics, but I suspect that they're generally useful. The other thing I would suggest, it's a little, I don't have a specific resource in mind, but Boston Children's Hospital has been working to both develop and design and think about policies for patient portals for children for years. And they have a very active portal, and they have active research going on. So they're really good thinkers about this. So that's another group that I think is a good resource. But I'm not aware that they've created any kind of a sort of a toolkit or a ready-made best practices list. But they've written a bunch of papers, and that's worth checking out as well. So that's what I think.
Thanks. John, I'm going to stick with you and ask you a question, a couple questions, actually. They're really good questions, it seems. One is, can you speak about implementing EHRs in a large adult hospital that has a small pediatric population? Now, I know, so for this question, I know, and I'm not sure if you mentioned during your presentation, but We the work group focused mostly on primary care, ambulatory care, but I think the question around, what happens if you've got, say, for a family practitioner, adults but has a smaller pediatric population, did the work group sort of tackle that, or do you have any thoughts on that? And then I'll bring up the second question in a second.
Okay. Yeah, my thoughts are it's really hard. And we had experience with this during this project in that when we visited state grantees in Pennsylvania, we visited a number of hospitals with pediatric groups that were functioning inside of those hospitals. And so as you can imagine, hospital system adopts big EHR, from a major vendor, whether it's Cerner or Epic or Allscripts or NextGen or you name it. They make kind of a corporate decision. And then what happens is that individual departments have to figure out how to configure appropriately. And in one case, with folks that we interviewed, they found themselves essentially using an adult EHR that had been, a corporate decision for pediatric care. And so they were supposed to then configure their, medication lists, order entry dictionaries, problems, everything for use in the care of children. And it just was very, very challenging. And some of that was not the system itself, but some of that was the policies that were in place for the parent organization. So the parent organization would say, well, we need to have one set of orderables for everybody, which would mean that if you were doing pediatric care, that there were just a ton of orderables that you would never use, and vice versa. So what we really found was that the ability to design and configure the systems appropriately to support pediatric care in a high quality and a safe way, it had many different layers to it. There were some restrictions that were placed by the vendor of the software, but there were sometimes the vendor of the software designed decent functionality, but the parent organization limited it, or the particular department introduced a limitation, or the specific implementation decisions were at issue, or the workflow was at issue. So that was one of the things that contributed to the complexity of the end users trying to figure out what to do when they noticed a gap. I think at this stage of the game, it's much easier to talk about the problems like I just described, and it's much harder to really come back with an answer of how you solve them, because it really depends on a lot of different factors.
Yeah, good answer. So we're pretty much close to the end, and the other part of the question is probably takes longer than a minute, but it's about how do you make sure all pediatric needs are being thought of and addressed prior to implementation? And rather than put you on the hook, John, for the last 30 seconds, I'll just say that it's a great question and repeat what John had said at the end, which is about the main use for the priority list is to spur dialogue, whether it's during the RFP process or during the implementation process, so that you can make sure that you ask these questions and you can compare to what you're being offered or what you've got to the kinds of things that this work group recommended should be part of your functionality if you take care of kids. So I would just encourage you to look at the USHIC at both the priority list and also the recommended uses, where you can find a little bit more detail about that. So we are at the end, and before we close, I do want to mention this. For those interested in obtaining continuing education credit for participating in this webinar, please visit the URL shown on this slide. You will, after clicking that, you will select today's webinar, which will be indicated by date and title, and then complete a brief evaluation of the event to claim your credits. You'll have 60 days to claim your credit for participating in this webinar. Upon exiting today's webinar, ARC is also fielding a brief evaluation, and we hope that you'll be able to complete that survey to share your feedback with us. I want to thank all of you for participating in the webinar. Thank you again to Dr. Wald and Dr. Alpern for presenting, and we hope you will join us for future learning opportunities. Thanks very much.